If we can bring up those slides now. All right, but hang in there, one last talk to go. So I was asked to talk about minimally invasive ablation for AFib and alternative lesion sets. And what we're going to try to do is talk primarily about one aspect. Niv has given you a little bit of a harbinger into that, and that's an epicardial endocardial hybrid ablation. We'll talk about it and its role in how we treat various forms of atrial fibrillation and perhaps some other devices as well later on, and certainly we'll have those discussions in the lab if you like. We'll talk, I think, importantly about the rationale for a hybrid ablation approach, and then in the theme of re-evolution, spend a little bit more time on things like patient selection, access and exposure, how you get there, how you get out, like we talked about yesterday in the lab. Some limitations about the surgical device technologies Niv was talking to you about, and a little bit about some of the results early on in this hybrid approach. So from my standpoint, when I talk about this, and I agree with Niv, I think that right now we're really concentrating on patients with persistent, long-standing persistent atrial fibrillation as being the patient population that we intend to deal with. For us, paroxysmal atrial fibrillation, given what Michelle Hasseguer has told us, is predominantly, from an ablation standpoint, in the realm of the electrophysiologists who, in large part, can create excellent pulmonary vein isolation. And in those patients that fail medical therapy, catheter ablation is reasonable. And we see very few of those patients, and I think appropriately so. But what we're really focusing on today is the patient with difficult atrial fibrillation, complex lone atrial fibrillation. We're not going to talk about concomitant ablation. We can talk about that in the lab if you want, but we're really talking today about is patients who have AFib and AFib alone. And so I wanted to talk a little bit about why we would consider a hybrid approach. So because, you know, as Niv told you, one of the I think challenges that Dr. Cox and Dr. Damiano and Dr. Ad have had over the years is that they've shown you an extremely effective gold standard for the surgical treatment of atrial fibrillation, but it's just not taken off. And so one of the questions I think that we have yet to answer is, can we simplify this by making it less invasive, as again is the theme of re-evolution, and perhaps make a dent in some of that. So one of the things that's true is that we cannot perform a complete maze procedure off-pump thoracoscopically. I completely agree with that. A complete maze procedure cannot be performed by catheter ablation alone. I completely agree with that. You can't make transmural lines with dots. Our EPs are excellent, though, at localizing and closing those gaps that occur in non-transmural failed surgical lesions. And they're excellent at creating conduction block in narrow, confined areas, perhaps that we can't achieve surgically. Biatrial macro-reentrant circuits maintain complex atrial fibrillation because the COX-3 lesion set works. Dr. Ad has just given you an excellent description of why that is true. So that, I believe, should still be the basis of any minimally invasive attempt epicardially to ablate AFib. Surgeons' tools are better are debulking these long lines of ablation than our EP colleagues, but their tools are probably better than ours at testing those lines to be sure that they're complete. So the use of both of these technologies, we believe, should allow us to interrupt all macro-reentrant circuits that perpetuate atrial fibrillation, reduce invasiveness without sacrificing results, and make the combined procedure safer and more appealing to our referring physicians and our patients. By doing this, what we're really talking about is a plan that allows us to work with, not compete with, our electrophysiology colleagues for the benefit of patients. And I'll direct you to other hybrid applications we've talked about, at this summit, TAVR, hybrid coronary vascularization. We find those programs to be exceedingly effective. So what we're really talking about is, let's just say we're talking about, as you've just seen, the documented left atrial macro-reentrant circuits that perpetuate non-paroxysmal atrial fibrillation. If we can have an anatomic way of ablating those, then it makes sense that we ought to have a highly efficacious procedure. So the procedure that we're talking about is one that creates bilateral pulmonary vein isolation with a bipolar bidirectional clamp that Dr. Ad talked with you about, using connecting lines, perhaps less efficacious products, but given some tools that we've and techniques that we've used, I think, become more efficacious to create the connecting lines that create that posterior left atrial isolation. We ought to be able to remove a great many of those macro-entrant circuits, align to the left atrial appendage, helps some more, and then ligating left atrial appendage helps even more. Now, as Dr. Ad mentioned to you, as part of the original MACE procedure, we placed radio-opaque clips in that area between the coronary sinus and the posterior left atrial wall to help with further ablation, and that's what we do in this minimally invasive hybrid procedure as well. So that the completed left-sided procedure looks something like this. So then our electrophysiology colleagues that have follow-up catheter ablation can come in now that they can see both electrophysiologically with mapping and fluoroscopically with these radiopaque clips can come in and create short lines of ablation to complete a AV valve line lesion set that ought to take care of much of this atypical left atrial flutter that we'll occasionally see after this sort of a procedure. So who would we consider using this procedure for? Well, obviously we're talking about patients with low atrial fibrillation that are highly symptomatic and have failed medical therapy. They have failed catheter ablation as well. It's particularly important, I think, that we are looking for patients who have poor results with other means of therapy, particularly those patients with significant AF burden. As I mentioned, those patients with persistent or long-standing persistent atrial fibrillation, and those patients with a large left atrium in whom the disorganization of their macro-entrant circuits is such that they cannot be managed in any other way. So the logistics of this procedure that I'm going to tell you about are, we usually perform it in a hybrid operating room. It can be performed as a same-day procedure or as a staged procedure, and we do have experience with both of these, and I don't know that we'll have time to talk about it right during this session, but if you want to, we can talk about it in the question and answer session. So we start, obviously it's under general anesthesia with double lumen tracheal tube to allow us to manage one lung then the other, and transesophageal cardiogram to, at least at the very beginning, assure that there's no thrombus in the left atrial appendage, and then assure us that we have complete left atrial appendage ligation, which I think is critically important at the end of the procedure. We'll start on the right side to create the lines of ablation that I just told you about, pulmonary vein isolation and those connecting lines. We'll move to the left side to finish the ablation, ligate the left atrial appendage, and then allow our EP colleagues to perform endocardial testing and ablation as needed. Batteries might have finally worn out. There we go. So what this allows us to do then, the surgical lesion set ends up being a bilateral pulmonary vein isolation, superior and inferior connecting lines, a left atrial appendage line, and a coronary sinus line. Right atrial lines can be done, and we can talk about whether those are efficacious or not. We've had lots of discussions about that recently. We do baseline EP testing epicardially and post-ablation epicardial testing as well. And if you believe in the ganglionated plexi and anatomic denervation, that's also something that's possible with this technique as well. So then our EP colleagues come in, map the posterior left atrium, test and augment any lines that we have, perform CAFE mapping if they think that's an important thing, and then proceed to the AV valve lines on the left and the right side to complete the lesion set. So this is a cardo map that basically shows we've done a pretty good job, except an incomplete area here in the superior connecting line. And again, that's a very easy thing for them to localize and touch up. So this thoracoscopic ablation is performed all endoscopically, beating heart off pump, using the radiofrequency devices that you'll see in the lab today. Depending on how you use these devices, we believe what we'll show you in a little bit, that it creates really very effective lines for ablating AFib. We're going to talk just a little bit now about some of the kind of logistics of this, and I'll mention some of these things briefly, but we'll talk about patient preparation, positioning, port site selection, pericardial incisions, retraction, sutures, dissection, and retraction. This is all the things that we'll go through in the lab this afternoon. So I'll try to move through this as quickly as we can. Positioning patients, it's a little bit like we talked about yesterday with the thoracotomy. You can elevate the chest either on sheets or with an inflatable bladder. I use the inflatable bladder because we started doing this at a same-day procedure. We can inflate the chest, as you'll see in a picture in just a minute. When we're done, we deflate them, and our EP colleagues are ready to roll with their procedure. So this is what the patient looks like either up on blankets or in our patients with these ROHO bladders to allow us access to the side of the chest for port access. I use 3 working ports. Some of my colleagues have used a 4th port for retraction. And like many of the concepts as we've talked about in the last 2 days, a wider array allows a little bit more working room and less bumping of the devices. From a port access standpoint, or we'll show you the array in the lab, but basically, and this is what it looks like surgically, we've used a combination of 5 or 10 millimeter ports, or scopes, I mean. The 5 millimeter scope, or port incisions are certainly more cosmetic, but the 5 millimeter scopes tend to be a little bit fragile, and depending on how much force you're putting on them, both will create the same view for you. So we start with the 5 millimeter port in the mid-axillary line, and then move to 10 millimeter ports through the rest, and so we end up with 3 10 millimeter ports. I know people that do this with 3 5s. We start, as we saw there, and then once we've achieved port access, we'll open the pericardium and begin dissection. For this procedure, it's all about the phrenic nerve. We talked a little bit about this yesterday, and making an incision safely around the phrenic nerve when we're talking about right-sided mitral valve access. Here we're talking about bilateral pericardial access. And if you injure one phrenic nerve, the patient is going to be a little bit short of breath and may not run a 4-minute mile again. If you injure both phrenic nerves, you might not get them off the ventilator. So it becomes really a very important thing. We dissect away the epicardial fat that often actually ends up with an envelope of the phrenic nerve, and then you can open the pericardium with a scissors, bovie, harmonic, whatever you tend to use. And again, you have to be careful about the anatomic course of the phrenic nerve as you're opening this up. Retraction sutures are important. We'll show you those today. This procedure can probably be done on the right side without them. On the left side, it is absolutely crucial to be able to see everything that you need to ablate and safely ligate the appendage. The oblique and transverse sinuses get then dissected to allow you access to the pulmonary veins, and again, we'll show you this in the lab. Basically, blunt dissection around the oblique sinus, and the transverse sinus is what you do on a regular basis transsternally, but it is a little bit different when you're looking at it through scopes from the side. And then we'll use a lighted dissector that helps us safely maneuver around the pulmonary veins that Randy Wolf developed at the very beginning of this procedure years ago, which I still think is a very useful adjunct for safely manipulating around the pulmonary veins. And we'll use that bipolar bidirectional clamp that Dr. Ad showed you, which I think is a superior device to make an ablation line on the antrum of left atrium, both on the right side and the left side. I use this particular unidirectional bipolar device to create those connecting lines. We can talk about that in the lab as well. We'll go to the left side and do the same thing. Again, encircle the veins, clamp the veins, finish our epicardial lines, and then ligate the appendage. Now, I think that I'm going to stop for just a second and talk just a little bit about this. I agree with Dr. Ad. One of the things that has been shown repeatedly in studies of the cut and sew and Cox 4 lesion set is that stroke prevention is dramatic. And that Dr. Cox thinks that may, well, it's certainly been helped by getting rid of AFib. He thinks it may be solely due to making sure that the appendage is completely removed from the blood pool. So what we don't really know is in an isolated setting if that's absolutely the case, but we think that that's potentially an advantage of surgical ablation. And while hundreds of patients may be getting done surgically and tens of thousands are getting done in a catheter-based way, I think one of our goals is to try to prove that this is procedurally important and really critical part of surgical ablation for atrial fibrillation and a potential advantage for surgery. So we use this particular device. There are several on the market. Applied epicardially, not in the circulating blood pool, compresses the tissue and actually helps not only to remove the appendage from the blood pool mechanically, but also is important in the electrophysiologic aspects of the maze procedure as well. That's part of the maze procedure, is removing some of the rare but documented places for left atrial appendage flutters and that sort of thing. So that is a part of the lesion set. I'm going to skip through the videos and that sort of thing just for time. So this is what the final lesion set looks like. Bilateral pulmonary vein isolation, connecting lines, line to left atrial appendage, right side of lines if you need, and these little dots here are our EP colleagues finishing things up and performing a left-sided and right-sided AV valve lines. One of the things that we've talked about, is that, and we'll talk about at the end, is that we believe that while this isn't a maze procedure, this is consistent with maze principles. So how have we done? Well, this is just a little compilation of some of the papers that I think have been written in the last 5 years or so about results from thoracoscopic ablation. And I think generally you'll see that these are numbers that, depending on your monitoring strategy and that sort of thing, are comparable to a lot of the data that's come out about open maze procedures. Now, admittedly, these are all really small single-center studies, and I think that's just one of the limitations of this procedure to this point is to get this in the hands of more folks and get the word out there to be able to operate on more patients. This is a paper that we presented at the STS a couple of years ago looking at a consecutive group of our patients that had continuous monitoring. And Dr. Ad and I have talked about this before. So one of the questions is how carefully do you look at patients and the success rate of these? So these were patients that either, if they didn't have permanent pacemakers in, we put internal loop recorders in to allow us continuous monitoring of these patients. And fortunately, we were able to show that the procedure itself is relatively safe. But I think the most important thing is what we showed is a follow-up of almost a year that a significant majority of those patients were in sinus rhythm, and that 76% of those patients were in sinus rhythm off antiarrhythmics, which is, again, as I think, comparable to a lot of the data that you've heard about the maze procedure. So limitations of this procedure, there certainly are several. We certainly, as I mentioned, need larger, better controlled studies of this sort of a technique. We need standardization of lesion sets, I believe, because everybody's got sort of a modification, and that makes it really difficult to study this scientifically. We need to determine the optimal timing of the surgery and catheterization. What we tended to see in our patients, so we did this on a one-stop shopping basis, is there's enough edema during the surgical procedure that when the electrophysiologists mapped the push to left atrial wall, they thought we did a pretty good job. But I think a lot of that was edema, then went away, and those lesions reconnected. And about 20% of patients, they had to come back for a repeat catheterization. And so we tend to now recommend a staged procedure. Let the surgery heal, and then come back for a follow-up electrophysiologic procedure. We need to improve the operative time by streamlining these techniques and, as I said, put this in the hands of more surgeons. So for me then, the way that we look at this for complex symptomatic lone atrial fibrillation, if you have non-paroxysmal atrial fibrillation and you're a candidate for a thoracoscopic hybrid ablation, that's typically where we'll go. And as Dr. Ad mentioned, a lot of times, depending on your relationship with your electrophysiologist, that'll happen now before they get catheter ablation. If you're not a candidate for thoracoscopic ablation, we'll either go down the road of minimally invasive Cox-Maze 4 or other types of perhaps less rigorous lesion sets that can be performed epicardially. And if not, then basically your options are catheter-based or medical. And in summary, then I'll say that thoracoscopic hybrid ablation is not the next generation of the Cox-Maze procedure, but I believe it is based on all the principles that make the Cox-Maze 3-4 successful. And that is making sure that you electrically isolate the pulmonary veins, interrupt to most, if not all, of the macro entrance circuits known to perpetuate atrial fibrillation, ablate ganglionated plexi if you believe that's an important part of initiation and perpetuation of atrial fibrillation. Locate and manage cafes and the ligament of Marshall, rigorously test all ablation lines, and manage the left atrial appendage. We believe it's been shown, at least in early experience, to be safe and effective for treating complex refractory AFib, that it tends to reduce the patient impact and can be more appealing to patients and referring physicians. And again, these types of hybrid therapies build relationships, referral patterns, and programs. Finally, I'll leave you with one last sort of summary slide, and this came from an article that Dr. Cox authored several years ago, where he said, what we're looking for here is an ideal minimally invasive ablation procedure that would be, begin to approach the efficacy of the Maze 3-4. And what we're looking for is something that's epicardial beating heart. We have an energy source that reliably ablates transmurally. We can treat paroxysmal AFib, long-standing persistent AFib, and a flutter. We avoid cardiac pulmonary bypass, is endoscopic, takes an hour, and in the absence of complications, the patients go home the next day. I would say we have not quite achieved that, but we're working in that direction. So finally, I would just say thank you very much, and I always show this slide to make sure that these two guys get thanked. This is Jimmy Edgerton, who taught me how to do this procedure, and obviously Dr. Cox, who taught most of the rest of us what we know about AFib. So thank you very much.